Now, so I'm starting with a Chinese philosopher about teaching. And he says here, tell me and I will forget, teach me and I may remember, involve me and I may learn. So actually, what it means for us today is that if you've got questions you don't understand or you think are wrong here, then please engage with me. It doesn't matter. Ask questions along the way, and then we can clarify that, and actually we can all learn from your experiences as well as mine. Sorry? Closer to the mic. Okay. Sorry about that. Now, when I was very kindly asked to talk, I was asked to present the latest evidence-based. That seems entirely reasonable, but actually I've got a confession that rather than giving the evidence from here, meta-analysis and so on, things like this, a lot of the information I'm giving you is from personal experience. And you can say, well, that's not so good, that's just one person's experience. But it does span 30 years of inpatient care and a leading service with lots and lots of changes. And of course, we're going to today get information from evidence-based papers and things like that, plus clinical experience. So I make no excuse for that. In fact, I think it's probably stronger in that respect. This is actually a latest paper just showing us that we shouldn't just have the pyramid of information, but we should be looking towards gathering information and systematically looking at this in picking the bits that we actually need. Like that. So the question really we've got to ask, what are inpatient services? What are the alternatives? Why do you need an inpatient service? Many child and adolescent psychiatric services completely run okay without any inpatient service at all. But when the patient, and adolescents particularly, are seriously disturbed, they're probably going to be admitted to an adult psychiatric facility, which is pretty daunting in many senses, I suspect, in the UK as in Turkey, unsatisfactory. So you do need something. Okay, that's fine. Do we need one? That'd be a question of your epidemiology and level of problems and things like that. And what are the advantages and disadvantages? Those are questions that I think we should be addressing today. And if we've got answers to some of them, hey-ho, that's presto, that's good. If we haven't got them, then if we haven't got them here, you're going to have to look it up somewhere else. The important thing about teaching is that if we don't know, we haven't got it today, and you get the inspiration to go and look for it elsewhere, then we've done our job. So let's start at the beginning. Admission. What is the purpose of an admission? And you can say, candidly, as an outpatient psychiatrist, is I want my patient treated because of the risks to him or herself, risks to others. Things have become too complex and there's difficulties in providing this inpatient, this outpatient care. And you might naively assume that you're going to get more intense therapeutic work on an inpatient service. And actually, that's not always the case. If you have regular once a week, if that's possible, therapy with one person on an outpatient service, actually that's not bad therapeutic work. In an inpatient service, time you take leaves, other things happening and things like this, often it's more difficult to match that, believe it or not. So it's not always about that. Actually, let's be candid, sometimes you might well ask for a patient to be admitted because basically you're stuck. You're not moving forwards, you're not moving sideways, the patient's not getting any better, patient's getting fed up with you, parents are getting fed up with you, I want to change. Instead of referring it across to another colleague, an outpatient, you might say, oh, if you went to an inpatient service, that might give you the answer. Well, it might. So actually sometimes, and I've had this before, an outpatient consultant will say, I just can't do this patient anymore. I'm completely worn out. Please take him or her off my hands. Now, you might think that that is really a dodgy kind of admission request. Completely sensible. If that therapeutic milieu, a duo, is actually worn out, then yes, that needs help, and that's perfectly reasonable. So you probably need, whatever inpatient service you're going to set up, an admission policy. And it's going to state something like, we're going to admit this age, these kind of problems. Are we going to exclude eating disorders or have eating disorders? We're going to exclude violence, this is that and the other, or exclude learning disabilities. So you're going to have some kind of policy or things like that. And that's reasonable, except in my mind, when it comes down to it, and you say, I am not going to admit an autistic child with an IQ of 50 to the unit with severe behavioral problems, and then your managers will come along and say, you're running an inpatient service, no one else will accept this patient, you've got to admit this patient. You say no, and the standoff will go on like this. At the end of the day, you will have to admit the patient. So you can have an admission policy, but believe you me, when the chips are down, it doesn't always count a hell of a lot. But, now this is the crucial question. If you're thinking up setting up an inpatient service, everyone will talk, we want to admit patients to your service. That seems obvious, doesn't it? I mean, come on, let's be honest. If you're an outpatient consultant, I want to know, can I admit this patient in the middle of the night or this within the next few days? That's it. Wrong question. When you're planning it, it's not about admissions that are really difficult. It's about discharges. If I run a 15-bedded unit and I am able to discharge, so I've always got 2 or 3 beds that are vacant, I can't come along to you and say, I've got no beds, I can't admit. And maybe the mix of patients is actually too difficult to look after, so it'd be reasonable not to admit that patient, another type of patient, the same kind. But basically, you could say that actually the important factor about inpatient care is discharge. And if you're running a service, the important thing is to be able to have a complete service that allows you to be able to discharge patients reasonably quickly and safely. Then you can continue. And I'll show you how that's done in a minute. Now, actually, many people will say, I want to admit this patient, and it's like, I'm going to take this car to the garage and have the tires changed. In other words, it's just accommodation. Surely there's something that's going to go on in this inpatient service, this box, that will allow things to happen and the patient to get better. Maybe a mix with other adolescents, more intensive care, nursing care, and so on, things like this. And as you say, a break from all the other services that are available. But it's not like that. Many people think it is. In fact, we'll learn as we go on today, hopefully, that there's a lot of things go on that are much, much more subtle. And one of the interesting things about hopefully about today's presentation, is that it's the concept, psychoanalytic concept of actually what goes on in an inpatient service that is important. There are other modalities of care that we will talk about in a minute, CBT, psychopharmacology, group work, family therapy, etc. But actually, you've got to have some understanding of what the inpatient service as a whole does. And actually, although I'm not proposing that a new service of adolescent care in Turkey is psychoanalytically run, no, I'm not, but psychoanalytically informed, I definitely am saying. So someone and some people in your service have to have an understanding of things like transference, projective identification, to be able to help the service work and you understand what you're doing. Because if you don't, you're just going to make a mess. And actually, a psychoanalytic view of admission is that actually you need an admission to a service when the social structures outside, that's family relationships, school, and so on, things like this, break down, so they can't contain it. It may be threats of suicide, it may be threats of violence, it may be that the person is spending all night with obsessive compulsive disorder problems, and things like that. The social structure just is not good enough to hold. Also, as I said earlier, the relationship between the patient and the therapist, if that's a consultant psychiatrist, is actually not containing. I can't take the worry that you're giving me every night. I need to be able to finish work at 5 o'clock, go for a swim, have my meal with my wife or husband, and settle down the children for school and go next day. I can't be up at 8 o'clock at night worrying whether you're going to jump off a bridge. That's not reasonable. Of course that happens, but all the time, no. So it's the social structures break down. And here we're coming to the transference relationships to the unit. Now, transference, for those who aren't being psychoanalytically informed, or that, what does this mean? Basically, it's a replaying of behavioral modalities or ways of working that you've incorporated from past relationships with carers, parents, and so on, things like this, so that you could actually have, give you an example, a very difficult relationship with maternal figures, because your relationship with your mother or whatever was actually problematic. And actually what you find in your life is that often, faced with the same or similar situation, you actually react in a certain way, angry, dismissive, and so on. You're replaying the relationships, the pattern of relationships that actually go back quite some way. And actually admission to the unit absolutely highlights those transference relationships, the same pattern of relationships against authority, submissive dependence, angry dependence, and so on, things that has come out to the fore. Now, it's important for you as a consultant psychiatrist or psychologist or etc., and staff to understand that these are very necessary. These are the bread and butter of what you're doing. And some people say, oh, he came into the unit and he was fine beforehand. You know, he had problems, but now they're many, many times worse. The transferent relationships build up and replayed, and actually you need to understand them and work through them to be able to make some therapeutic headway. Rather than just say, oh, well, he's worse, he shouldn't be here, we'll transfer the patient. Sometimes that's necessary because the disturbance is too great, but if you can work through that transference relationship, then you've got onto a winner. And I'll try to show you through that. So, this is the patient. Here. And these are the many multitudes of staff members that you've got here. All attentive, except for this one over here, who actually is on his phone on the admission process. No idea, no interest. You ask him what's going on, he'll say, I don't know, conduct disorder, a girl with anorexia. The others are actually paying attention. But what happens is that this patient comes in who's already exhausted the social structures outside and has multiple split transference projections to other people. Now you might say, hang on, this isn't a talk. I thought we were here for psychopharmacology. This is a base to be able to do the psychopharmacology. The question really is, when the person comes in, he or she will split off part of their personality to various people in the room, and those people will be receptive to that. Now you might say, oh, hang on, this sounds airy-fairy. I don't really understand what you're saying when you say split transferences. I'll show you a simple example. If you say behavioral or behavioral characteristics of a person are set and fixed, that's a very narrow view. If I was to say to you, how you relate to your mother, oh, she's charming, she's hard work, she's diligent, X, Y, and Z, is going to be very different to your projection to your lover. At least I hope so. If it's not, you're really in trouble. You should have a different type of relationship with different people. And this is what's happening here, that actually some people will have a view about that patient. Oh, he's very angry. He's bossy. He's a delightful, misunderstood young man. Oh, I don't know, he's just nondescript as far as I can say. These are essential elements to pick up, but you can see they're very different based upon each one of the staff's personal experiences and receptivity to those kind of things. For instance, you may be highly sensitive to angry people because of your past background, or you may be highly sensitive to someone who's dependent, and you're going to react in a certain way. So these people are going to have different experiences, and that's perfectly fine. Now, this staff member over here is extremely negative. Oh, he's lazy, he's arrogant, we're just going to have trouble with this patient. Nothing we can do as an inpatient service is going to help him. We need to get rid of him as quickly as possible, perhaps not even admit him. Tough cheese for anyone else who says that. While this staff member says, oh, no, actually, I can see that he's actually underneath it rather dependent. He's been post-traumatic stress disorder. He's been through a lot. We can work with that. We've got expertise on this. This is what we do. And I definitely think this person needs admission. So you might come along and say, oh, wow, how can this staff group work? They're very split in the way they work. So a question for you, my first question to you today is, where do you get 12 bodies together in a room that do not have differing opinions? 12 bodies together that do not have differing opinions. Well, I'll tell you the answer, it's a morgue. If you've got live people, then you are going to have differing opinions, and that's the real benefit of an inpatient service. It's not splitting is bad, splitting is good because of the next slide. What happens is after 3 weeks of admission, this person here, who was highly negative, positive before, actually is highly negative. Oh, I was completely wrong. He was just rubbish. My colleague was completely right. He's dependent, he's lazy, he's awkward, this is that and the other. I can't do anything. Forget the post-traumatic stress disorder. It's just a waste of time. And this staff member, actually, I've changed my mind. He does seem to have certain characteristics which we can help. Now, hands up, who's been in an inpatient service where that's happened, where staff have had completely swapped over their views about what is important about this patient. Well, there we are. There's at least one. And how come you use this? What we contend is the patient splits off these parts of the personality and the way of behaving. It affects the staff, and that's fine if there are differing views. What you need to do is be able to have the staff talk to each other, such as this staff talks to that staff, talks to this staff, this is that, and the other. So actually what it is here, they metabolize these ideas. So the split is really looked after. Now, the contention I have is that if you've got the patient in this setup, in this system here, then he or she will understand that their difficult parts of their personality can be, first of all, held, understood, worked on, metabolized, and passed back to them in a form that actually makes sense. That's a crucial part of admission. And I'm sorry, you will not find that easily in a textbook or wherever it is, because that is an essential part of an inpatient service. And it doesn't really matter if it's a service run on behavioral lines, CBT lines, or psychopharmacology, or systemic level. At some level, this needs to happen. If it doesn't happen, you can't run the service. And if you're asked to come in as a CBT therapist to consult to a service and you wonder why it's not working, start doing this work and the service will work. It's nothing to do about CBT, it's nothing to do about systemic therapy, it's to do with the milieu and so on. And we'll go on to talk about that later. Now, a crucial element of hospital care is the nursing care. Now, you may be, as doctors, psychologists, etc., think, actually, that's rubbish. I'm paid a lot more experience, and it's very important that I'm there. No. It is important you're there, and it's important that you're trained and you can provide leadership and understanding and the in-depth therapeutic work and leadership the unit needs overall. But are you going to be there at 5 o'clock at night when the first incidence of self-harm happens? Or 3 o'clock in the morning? Or 7 o'clock the next morning? No, come on, you're not going to be there at that time. And nursing care can provide the holistic, overall arching support. And all right, often it's more female than male, but it doesn't have to be. But the care is maternalistic or paternalistic, and that's the important thing. Now, you can get very different types of therapeutic nursing care, and it does, and I have traveled a little bit. So in Spain, often it's more guardianship. This is what you do, this is the time we feed, this is what we do, and so on things. And the therapy comes from the doctors on high. This is missing such a wealth of therapeutic care. I can hardly believe that. In the UK and in Germany, Germany are very clear about that. The therapist does this that work. Lunchtime, they go off. Why would we serve meals to patients with eating disorder? That's ridiculous. We just go off, and have our lunch. In the UK, you sit down and have meals with the patient. That's actually therapeutic. And during COVID, when we weren't allowed to do that, we saw a real different relationship with the patients when they couldn't eat together. So the question then becomes, how do you engage the nurses there? Now, I'm not familiar with the structure of nursing care in Turkey, but in the UK, we have trained nurses, that's a degree nurse, and then we have what is called healthcare assistants. And these are usually psychology graduates who come to get extra clinical experience before they can get on a rather tight, difficult course of clinical psychology. So they do their degree in psychology, come to the Highfield unit to do a healthcare assistant, and do that for about a year or 2 years to learn about how to deal with patients and then get on the clinical course. They're magnificent. Often have 2-1s, first from Oxford or from other universities. And because of our hierarchical system, they weren't allowed to do therapy. Now, I'll come to a treatment modality in a moment, which I highly recommend for eating disorder, called Enhanced Cognitive Behavioral Therapy, CBTE. And it's online, it's free, from Oxford, from the Credo Institute. And we trained up all our HCAs in this. And during the COVID crisis, we had a hell of a lot more eating disorders come in. We didn't have enough psychologists, but we trained up 8 HCAs, fully trained in CBTE. They took it to, like in English saying, duck to water. Fantastic. They took on the care. I had to fight the nursing and the psychology hierarchy to do it, but we said we provide supervision for them, and it worked like a dream. So if you don't use your nursing care right through the hierarchy, you're losing a real benefit. Okay. So, is there an alternative to inpatient care? This is a paper done, a lot of work's been done by this person here, who's professor of child psychiatry down at St. Bartholomew's Hospital in London. Denis Nguyen. He's Ukrainian, but he's really quite a smart person. He's done a lot of work on self-harm, so he's completely familiar with the reasons why you should be admitting a patient to an inpatient unit. But he did this study to say, well, what they did was they did a randomized trial to show inpatients versus day patient, inpatient. But this first trial is the patient had been admitted. They went to the patient after 2 or 3 days of admission and said, would you like to continue as an inpatient, or would you like an enhanced community care package? And so they did. It was randomized at that particular point. So it's not admission, but after 2 or 3 days. And what they found was this, actually, inpatient care is extremely expensive. I was working with the head of NICE, National Institute of Clinical Excellence, who actually said that for every patient admitted to an adult bed, you could treat 30 community adult patients. So the ratio is 1 to 30 for adult inpatients. Do you want to have a guess what it is for adolescents? 100 to 1. So for every inpatient you're admitting, you could have treated completely in the outpatient service 100. So there's no, sorry? I can't hear you, sorry. So you can see that actually you might well be advised, if you were a medical officer for the district of Istanbul, part of Istanbul, to say, actually, I don't want an inpatient service because I can treat a lot more patients. Trouble is, you're going to still have patients that will cost quite a lot to treat elsewhere in the private sector. So there's a question there. It's extremely expensive. What you can do now, and we've now got evidence that some day patient services or outreach services can provide really good intensive care. We did a paper on the admission of patients with early onset psychosis, and after the introduction of early intervention psychosis, our inpatient care for psychotic patients dropped. Previously, when Dr. Gomez was at Highfield, a third of our patients were patients with psychosis. Now we get 2 or 3 per year. It's completely transformed. Those 2 or 3 patients are a nightmare to look after, though, I've got to say. So you still need some resource. And we've similarly seen the same thing with eating disorders. You can treat eating disorder patients with CBTE and with treatment at home services. So you can. But the community service, going back to the trial, was associated with fewer days in hospital, fewer days in care, and actually the patients seemed to do quite well, got back to school better, and the rates of self-harm were twice as high in an inpatient service. So that's pretty daunting if you're thinking of setting up a service. But you can't have an inpatient service isolated. It's got to be connected, highly dependent on outpatient services. So if what we've done in the UK, and I would recommend here in Turkey as well, is have highly developed crisis services that run through the day and night, so that someone actually having problems can actually take a phone call. If it's a dialectical behavioral therapy service, they can actually have someone who's in the team can support them. And it works very well. We have now hospital at home, so that patients are referred to our service, and we can say, can the patient be treated at home? And what they do is purely online treatment. They do not see the patient face to face. They do the patient's raid at the GP and have support for the individual patient and support for the family and dietetic advice. And some patients really love that, and it seems to be doing quite well. We're now going towards ASD and learning difficulties for the same kind of thing. I asked and said, I thought, this is crazy. How can you have patients going to be supported with autism on the phone, online? They don't even pick up the telephone. but actually I think they are adjusting their service so some patients will be seen at home directly. Now what I recommend today is that you need to go back go back historically. Because when I started at the Highfield unit about 34 years ago, my predecessor had a community psychiatric nurse on an inpatient service. And what she did was go out to the schools, to the family home, and you say, oh, we have InReach. That's not the same thing. If you place the nurse on a service outside in the community, they become acculturated to that service. And actually, they'll say, oh, I can't come into the Highfield unit. I've got to see, this is an assistant. And before you know it, they become just an extra worker in the outpatient service. Whereas if you have an inpatient outreach nurse, they go out, they know what the ward is like at the moment, they can take the patient out and so on, things like this. And the patient and nurses, they met them on the ward, they can be reassured, they know what's going to work. And it works like a dream. So the trouble is, I can't persuade my management to actually accept this, even though I know it works. What happened over the years is we were short of staff, and of course the person was pulled back in. So if you are running an inpatient service, do not pull back services into your inpatient service. Otherwise, you'll just destroy the services that you need to have outside. So, how does your inpatient service actually work with the rest of the community? Because this is it. As I said earlier, it's not an isolated island. And here we have the old model, so that actually the inpatient service would have the best psychologists, the best nurses, this is that and the other. So if you were a community psychiatrist, you say, oh, this patient's too complicated, I'll just refer him to the inpatient service. And they say, yeah, sure. What happened is, of course, the patients would be admitted, and before you know, just a few weeks or a few months, the inpatient service is completely full. And they say, would you take this patient? And say, don't be stupid, we've got 15 patients and 3 on the waiting list. Well, that's no good to anyone. And they said, but you have all these super duper psychologists and things like this, what are you doing? I said, I don't know, I can't help you, we're full. Of course, the model is wrong. What you need is this, a linear rather than hierarchical model. So that patients are admitted, you have a more equal balance of specialist services throughout the community and inpatient service. In fact, I would suggest you need a rotation of psychologists, psychiatrists, so they actually have inpatient, and then they know exactly what the broad range of treatments you can offer in your district. And actually patients can then come in, you have what is known as a care coordinator. He or she will remain involved in the care of that patient throughout, and actually come to ward rounds, meetings. We have our ward round online, so they can drop in at any point. They can see what's going on and then drop out. That's in theory. Of course, what happens is you're an outpatient psychologist. You put your patient in inpatient, and you say, thank God for that. And forget all about your patient. And we say, it's 6 weeks you haven't seen your patient. Oh, can you come to a CPA, care program approach? There's a meeting where, and they'll say, I can come in 3 weeks' time. Instead of having that interactive service where actually the therapist has continued to see the patient, not necessarily continue to do the therapy, although sometimes that is possible, but actually having that integrated linear model actually works. This doesn't work. That needs really active management. And actually, I've got to say, it has to have a management structure above it. It's because you can imagine if you're an outpatient therapist, you're going to say, out of sight, out of mind, I'm overworked, I don't care about that. Just give it to me, I'm fixed when it comes back, and it won't work. Right, so this is nationally, Great Britain, this is just England, that's all, so part of it. These are the number of beds that we actually have. Half of them are general adolescent units throughout the country. what you see then is very few learning disabilities services. They seem to be a Cinderella service altogether, 28. And actually, when you think about that, that's entirely wrong, because we know that as the IQ drops, the prevalence of psychiatric disorder increases. So they should have proportionately more psychiatric beds than we do. Children's inpatient services, I think 64 are probably actually top max count. They've been shutting all around the UK. And I think that may well be right, because actually admitting children to an inpatient psychiatric facility is highly disruptive to the child and the family. Although you do get neurodevelopmental difficulties, childhood onset schizophrenia and psychosis, very difficult, but impossible to treat as an outpatient. So you do need some in each region, but very difficult. What I think you need better is to have family centers linked with social services, so you can do day care, residential care, because often the issues, especially the emotional, behavioral, can and should be best dealt with as a day patient service. Eating disorders, in the UK, a good proportion of those are private, because they're a good money spinner. And you need, if someone's actually starving themselves, really physically unwell, then you need an inpatient service. We run our service, don't use the inpatient service that greatly, but you do need some, and as I say, the private sector provides that. Deaf inpatient, I don't know very much about that. Psychiatric intensive care. So if a patient is severely disturbed, and I mean self-harming continuously or using extreme violence, then you do need a service above the general adolescent service, because our services aren't locked, for instance, but you do need a specialist service. And it's quite difficult, because actually they're meant to have a very short-term support service, say 6 to 8 weeks, and then return to general adolescent unit. What they do for those with autism and learning disabilities, there's a new treatment package called Positive Support, Behavioral Support, PBS, which works very well. They do a complete formulation, understanding what the purpose might well be of such and such behavior, if it's self-harm and so on. Understanding the child's learning difficulties, sensory issues, and particular foibles that may well arise out of autism, and actually devise a treatment program around that. And actually it can work very well, so that there's that. But the question then becomes, if the patient still remains disturbed, how can they come back into a general adolescent unit, or do they need to go to low secure, which is another set of care here. The trouble is that actually if you get one going and another one goes and things like this, you can get a cohort of young people, say from Oxford or from London, who know each other, self-harming together and things like this, and you can fill up your residential secure beds quite quickly. And actually it's quite difficult once they're there for them to come down. So you really need to work on that. Medium secure, that's for forensic type cases here, and so on. So, you need to look at the population of Turkey, and it's changing. I suspect in the UK, as in China and other countries and things like that, the fertility rate's going down, birth rate in Western countries is going down because mortgage rates, contraception, a whole host of reasons, sociological reasons, nothing to do with psychiatry, but actually there will be a gap. So if you're building units, you need to be aware that it has to be flexible to the population demographics. But this is the UK. This is Office for National Statistics. You have the same here in Turkey. So there's 16 million adolescents in the UK, 57 million. So the number of beds per million population is 21. So actually, if you've got a population, I think the population of Istanbul is what, 18 million? Well, you can see you're probably not going to build a unit that's 18 times 21, but actually you will need some beds. And that actually is best to do it in epidemiological ways of thinking. So this is just Thames Valley. What we found in Thames Valley is that we would send patients privately to some unit because of severe self-harm or eating problems, and they go there for 3 months, 4 months, and no one has actually seen them from Oxford. But you're paying bills of, say, something like £1,000 a day, and no one's seen the patient from your locality for 4 months. And actually what we were forced to do, was actually collaborate with all the units within a certain region, so Oxford, Swindon, and then the private sector, combined to provide inpatient care beds, intensive care beds, no learning disabilities, and combine the budget. So the budget came down to us, and within the first year, they saved £7 million, which is quite a lot of money, because we weren't paying out of areas, and out of areas were brought back and actually treated locally. And it's better, because the family prefer that, and it's better for their care, and we understand the patient, and save £7 million, which is one hell of a lot of money, I contend. It's not without its difficulties, but that's how we've done it. But again, if you're an inpatient consultant, you've got responsibilities to look after the patient, the family, the management locally, but you have to look upwards to see what the national picture is as well. You've got to be involved in that. Now, has anyone got an idea who this is? Probably not the most attractive photograph of him. Anyone an idea? He's probably one of the leading psychoanalysts of the last century, beyond. Why? Don't start reading some of his books. The only one to read is the group work, because that's actually quite easy. I think we spent as an analytic group 2 years reading his book, which is 136 pages. It's incomprehensibly difficult. It's very difficult. But his ideas are seminal. That's it. Elements of Psychoanalysis by Bion. And he was actually an Oxford graduate, believe it or not, Anglo-Indian. And one of his important concepts, I did say today to warn you that there are quite a few psychoanalytic concepts, containment. And that's vital for inpatient service. You have to be able to contain physically and emotionally your patient and your staff. Because if you can't do that, you can't run an inpatient service. And in order to be a containing, you have to have a container. So what it means is if you're the inpatient consultant, you have to build relationships with your staff so they connect up, so you know who the staff are. So you've got a safe, secure, supportive environment here. That you know your staff, you know their difficulties, their weaknesses, their strengths, and then you can provide a container. Now, what about this? Rather idyllic pictures here of a mother and baby. This is a unit that actually will be important for containment, as we'll see. When the baby actually looks towards its mother, the mother will pick up on certain things. You've fed the baby, you've breastfed it, you've changed its nappy and things like that, and still the baby's not settled. But there's something in the reverie that you'll be able to contain his or her projections to you, to the mother. Metabolize it and pass it back to the baby. And Bion particularly said, we don't know what this process is, we'll call it alpha processing. Whereas actually sometimes the child will ask for project into the mother some need. And the mother might be, because of preoccupied, depressed, on drugs or whatever it is, can't process this. And actually the child passes pang, come on, pay attention to me. And the child doesn't get anything back. And the child becomes increasingly neglected response. The child becomes anxious, agitated, and angry, and either turns towards hallucinations or psychosomatic or behavioral acting out. Now, I can give you an example of this. So you're studying for an exam, okay, on differential mathematics, okay? Something not that simple. And for some of you, that will ring an alarm bell straight away, and others will be super simple. But you're trying to work out this equation, you can't work it out at all. You go to a professor and he says, oh, so. But fine. You've learnt nothing, you've got the answer, but you've learnt nothing. That's just passed off. You go down to the canteen, and the canteen lady comes up to you and says, are you all right? Is everything okay? I think you need a cup of tea, don't you? Suddenly the answer comes. You're in a containing environment. The canteen lady or person has not helped you about differential maths at all, but actually provided some emotional support for you to be able to work it out yourself. Does that make sense? Have you had that kind of experience? Okay.
Dr. James, I'm sorry for interrupting. Dr. James, I'm here. But I know you have 20 slides, but time is up actually. I thought we had time till 4:30, but it's until
how much time do you want?
Only. It's actually up, maybe just 5. Time is up, just for 5 minutes, maybe 10 minutes. We can wait longer.
10 minutes?
Yeah.
Okay, super. So that's what the child has. So you need containment. Treatments, you can have psychopharmacology, CBT, group work, family, psychosocial, and media therapy. We have a weekly Highfield group, which allows patients to actually sit, think about things, and we have supervision from an outside Kleinian analyst. And what you can do is facilitate us to work on the transference relationships and projective identification that's going on through the unit. I'll miss that. CBTE, as I've told you, if this is a Credo, if you look up Credo Oxford, you can see there's online free training, you can do this. CBTE has changed our eating disorder program. Before, in 26 years, I had not discharged one patient completely without follow-up care. In the matter of introducing this, within 18 months, 6 patients were discharged completely without any further follow-up. Makes a difference. So the philosophy of treatment is this: active collaboration, not passive. We can help you help yourself. It is not we fix you. But we must actually, if you're setting up a service, claim expertise. It's not all about psychotherapy. You've got to be able to do advanced psychopharmacology, clozapine, ketamine, and things like that. That's what we provide. And must be all these things, responsive and dialectical. DBT on a unit works really helpful. The thing about an adolescent service is that it is highly socially contagious. If there's an experiment done, adults driving in a car take a certain level of risk. Adolescents driving in the same kind of car, same situation, have exactly the same level of risk. Put another adult with the adult, the risks remain the same. Put another adolescent with another adolescent, the risks go through the roof. Adolescents are highly social, and this is why you've got to be careful. I think one of the things quite difficult to understand this is that patients admitted are not necessarily the most disturbed. You can have, and this is quite difficult, patients actually pick up on the projections from their parents. So the parents may look actually sensible, professional, business class and so on, things like this, but actually have psychological deficits which they're projecting into the child. You actually see the trio and realize the child's disturbed, but actually the adults are far more disturbed. Anyway, question, finish off then. I have a treatment that is evidence-based, free, universally available, no side effects. What is it? And we don't research this enough on the inpatient service, and we should. Sleep. It works, it's free, it works, and it actually, if you can help the adolescents, the trouble is adolescents actually don't want to sleep. They want to be on the social mobile and things like this. We've shown that actually sleep deprivation is associated highly with the thing we do. Thanks for listening. I have a video to show you if you want, but it's up to you.
Build unit. We've made a little virtual tour to show you around.
This is the reception area.
We go through these doors onto the ward.
That's the nurse's station in front of us.
We call it the fishbowl, as it has windows all around it. This is the main corridor where the clinic room and day patient lounge is. It leads down to the dining room where we have our meals.
Across from the dining room is the games room.
There are lots of activities to do. In our free time, we like to attempt to play pool, table tennis, and table football.
And we like to play the piano in here too.
Outside, there are 2 gardens we have access to.
You can play basketball and netball, and you can have visits from your pets as well. If we go back up the corridor, we come to the main lounge where we hang out, watch TV, and play bananagrams.
Be warned, your child will become a bananagram genius by the time they leave. This is corridor 1, which has 8 bedrooms, a side lounge,
And there is a communal bathroom if you would like to have a bath.
And here Lucy greets us with a graceful curtsy. This is what the bedrooms look like. You can decorate them with pictures or posters so it feels more homely.
So that's it. Actually, it's a real problem with that because one of the things I really wanted to show you was actually it's quite spacious. A lot of light, a lot of room. The corridors look narrow because of the angle of the thing. They're at least 7 feet, so it's about 2.5 meters wide. And that's important. One of the important things is enough light and enough space. Because if you wanted to reduce disturbance, you've got to have that. Okay. Thank you.